we have Mark Brown, who is Development Director of Social Spider. What a great name for an organisation. And that's a community interest company. Fantastic. Great to have you here. We've got, next we've got Antonis Kousoulis. That's a great name. He's Director of England and Wales for the Mental Health Foundation and runs some really interesting programmes, very relevant to today. We've got we've got Natalie Creary, who I met when we came in, who's Director of Black Thrive. What a fantastic, dynamic name for an organisation. We're going to hear much more about that. And John, who's Professor of Public Health and Psychiatry at Swansea University Medical School. So, big round of applause for a very interesting panel. And Robbie Cochrane is going to join them. And perhaps by way of introducing yourself, could you just say a little bit each for a couple of minutes about what you think mental health prevention actually means for you? And then we'll get into a conversation. We're looking for good questions. There'll be some questions from outside the room as well, in that we're speaking to outside through Andre and others. But let's have just a little dip on mental health prevention. What does it mean for you? I said that actually for somebody who's had quite a few mental health issues in my life, it means me staying in recovery actually, from a personal point of view. And that for me is someone to love, somewhere to live, where I can relax, and something meaningful to do. And do you mind picking up on that one?
Okay, so to me, I come from a sort of primary care public health background.
Sorry, can everybody speak up a little bit, please?
Okay.
So
I come from I was a GP, come from a public health primary care background, and I do research, mainly in big data, but it's very technical at the moment. To me, I think prevention is really important. It's always been under-recognised. I think that's slightly changing. But I think the first part of it is, we know that a lot of mental health problems start when children are young. You can see the roots of it there. And minimising adversity for young children, young people, and maximising protective factors is prevention. And I think that includes all the things that you're talking about. It's about having trusted adults, having somewhere to live, having a good education, not being excluded. It's all those things. And that is where we can do things at a population level. And sometimes that requires political will, like addressing poverty. But also, we shouldn't forget the people who are at risk. We know that certain groups, like looked after children, are more at risk. We can do extra things for them. And then for people who are ill, we know there's a massive treatment gap. We've talked about the research funding gap. We know there's a prevention gap. There is a treatment gap as well. There are people who are ill who are not with complex needs. There are people who we don't even recognise within services that they have needs. We need to make sure that those people have good access to services and environments to make a difference.
Lovely.
In a nutshell.
Thank you. Mark, what do you think?
I think, thought hard about this. The first thing that I think about in terms of mental health prevention or prevention of mental health is we're not really preventing mental health, hopefully, because we're actually kind of quite good at that. I've noticed. We're actually trying to prevent mental illness, yes. which is definitely a different order of task. The thing that kind of challenges me thinking about mental health prevention is that for the group of people I'm closest to what you might call a constituency of people, we're the people for whom it hasn't been prevented. And I think it's really, really difficult when we're talking about kind of prevention of mental ill health, because we're not talking to people for whom the prevention of mental ill health was successful. We're actually talking to people who have become unwell. For those of us who have difficulties, those of us who have challenges. And I think that there's a really interesting thing there in that if you're successful in your prevention of mental ill health, then nothing happens. And in policy terms, people go, well, wow, we spent all those billions of pounds and look, nothing happened. which makes it kind of very, very difficult to make the argument successfully that we should be taking like large actions at population level to prevent the things that cause people to be unwell. But I think also as well, kind of coming from my perspective and the perspective of people who live every day with long-term experiences of mental ill health and distress, there's kind of a bit of a challenge in the way we frame the idea of prevention and mental health, because we ultimately sort of say to people, well, what we'd like to do is not spend any money at all on your care and support. We'd actually kind of quite like to cut that, because we really want to spend that money on preventing people turning out like you great big mess. And I think that's a massive problem in terms of getting people with severe experience of mental health difficulty, people who live with severe distress, on board with the discussion of prevention, because you ultimately are saying, if it was possible for your life to have turned out differently, which it hasn't, can you tell me how you would have liked it to be? So I think there's lots of really, really confusing and difficult kind of cross currents in this discussion for people who experience mental health difficulty.
Yeah, wonderful. Natalie, what's your take on it?
So I think I've been in agreement with all the points that have been raised. I think it's about how you prevent people from becoming ill in the first place. For those that do experience mental ill health, how we can prevent them from, and support them during recovery. And yes, in terms of a lot of it does kind of manifest itself in the early years. I think for me, where there's the sort of like the absence in the discussion, when we're thinking about the disparity that we see in the experiences of people. So my work is largely looking at the experience of Black communities in terms of their experiences of mental ill health. It's actually really started to think about the structural barriers. And I think that's often absent from the narrative, and in particular, people's experience of racism and how that has a profound impact on both your physical and your mental well-being. And I think that's, for me, an area that is a real issue. And I think some of the research that I've done, one of my participants said something that really struck me, and she was saying that when she was in therapy, that she wasn't actually able to talk about racism, and that her therapist didn't accept it. And she said, that's the source of my pain. How can I get better? So I think it's really important that we do also pay attention to the more structural elements, because it's about housing, it's about education, and so forth.
Antonis, no pressure. There's some great points that you made already.
There's much to add. I think from my perspective, you've mentioned some of the stats. We had the new stats this week. 1 in 5 girls self-harming. So a lot of disturbing statistics. Regardless of the lens, I think if it's the structural inequality, the population level, the recovery. For me, what prevention means, the scale of the challenge is so big that it's the only reasonable answer. So I think there's no point in keep investing in beds, keep investing in hospitals when we know there isn't actually an end game. There isn't actually a point where we can get to that we can actually help everyone who is experiencing distress at any point every week. So for me, prevention is the only thing that makes sense.
Let's open it up. Any comments or further questions? Move it on, please. You're the others. You've made your way here. We're giving you priority before we go outside the room. Any thoughts? Any questions? Yeah, please. Hi.
Hi.
Just introduce yourself.
Mark Bowen from the Mental Health Foundation, and so I just thought that was a great summary. Mark's point about sensitivity of prevention, I think, is really. I just like to kind of explore or hear other people's comments, because I find that when we articulate the case of prevention, or we talk publicly about it, we say mental health things can be prevented, there is often there's such a deep sensitivity. It's this balance of not trying to own someone else's narrative and redefine and talk about someone else's life, and yet I think it has inhibited, the sensitivity has inhibited being able to say some really direct things like mental health problems can be prevented, or can we agree that no one is born with a mental health disorder? And even some fundamental, simple statements are still contested. And how can we open this discussion up to be able to really, and I think some of that sensitivity has held back the degree of evidence and resource that's been brought to bear on prevention. But at the same time, as a charity focused on prevention, there is real responsibility for those who are talking about prevention to not stereotype or alienate or be pejorative about somebody else's life experience.
Mark, do you want to come back?
Yeah, I think there's a couple of things in that. We talk about eradicating mental illness rather than talking about kind of mental illness in the context of disability, for instance. So we talk about eradicating mental illness rather than eradicating the problems that can be caused by mental illness, which I think is a really different idea. So we don't talk about how could we create a society that mitigates the effect of being neuroatypical. What we talk about is how we might remove that experience completely. And you can see why that might kind of knock people off a bit. Because you basically say, well, you know, you might have got to age 55 and experienced the thing that we often call schizophrenia, or you might have had an eating disorder or anything like that. You say, well, actually, you know what? You're just a kind of category of problem. Like, you might have struggled all this way, but what we're trying to do is actually eradicate people like you, which kind of has some kind of unpleasant undertones, I think. And a lot of the stuff that we say about, you know, people being service users or survivors comes with claiming that identity. And the prevention stuff often claims that actually that identity is sort of invalid, that eventually if you can just put aside being all fed up and unhappy with the way the world is, then we'll get to a point where your kids won't be like you. And I think there's kind of a really, again, really complicated set of kind of emotional currents in that.
Do you want to come in now? Yeah, hi, say hello.
Hi, I'm Samir Jaraj from the Race Equality Foundation, and I've done a fair amount of work in the experience of black and minority ethnic people within the mental health system, and yeah, it's a really interesting discussion that we're having. One of the things that kind of came to me was that because I very often hear about people's terrible experiences within the system, and we know that black and minority ethnic people are more likely to have the worst experiences. My kind of thought on prevention was, you know, my instinct is great. Let's keep people out of this quite often terrible, if not often very dangerous system to their physical safety and security. That actually kind of it's kind of quite a weird way of thinking about it in that kind of sense. But actually, kind of like prevention for me is kind of keeping people out of systems that actively harm them. So, for example, keeping them out of the criminal justice system, which we know people with mental health conditions are more likely to end up in, and keeping them out of services that are more likely to harm them. I think that's kind of was my kind of very thought on.
Yeah, thank you. Anne, can you help us reframe this a little?
So there's a couple of things with that. So I think that's where the minimising adversity, because I've thought about this so much, because it's like the resilience word, isn't it, that gets used so much, but the way it's spoken about is very much like you're not resilient enough, and that's where I started thinking, okay, minimising adversity, maximising protective factors that captures some of that stuff without, you know, blaming or shaming. The other thing I'd say is some of the tensions you were talking about also really exist for services, because on the one hand, you know, when you're trying to invest resources into prevention, the people at the front line trying to manage people with complex needs or trying to support people early or find the hidden people, there's a tension in that. It's almost like people are pitched against each other for those sorts of funding. So I think those tensions about prevention exist across the system. And I think, you know, for people from black and minority ethnic backgrounds, all those tensions, isn't it, can be harder. you know, we've talked particularly about those as a high-risk group, and I'd completely agree.
Is there something about asking what you want your life to be? Certainly, I've dealt with a lot of colleagues, a lot of people. I even used to get referrals as a chief exec of very senior people who were going under with stress, depression, all sorts of things. I'm not a clinician, but I'm a scientist. But you know, I say, well, what do you want your life to be? You know, there's something about getting in control, something about trying to create hope and opportunity for people. And I've learned a lot. I'm a much better person for having had a mental health issue. And my family tell me that too. It gave me a lot more emotional intelligence, gave me a lot more insight, and it gave me empathy for people. And I think there's a just as an example, specific examples, a group of Asperger's, a community of interest in Nottingham who work with Institute of Mental Health at Nottingham, and they see patterns in research numbers that some others don't, and they actually have some paid employment in terms of working with the scientists there, and it's a really fantastic, very co-produced partnership, very respectful of the skills that people who are, I think you said atypical, neuroatypicals, can actually give. And that's where I get the word superpowers from. That they granted me the opportunity to use that word, and it was a great opportunity. So reframing it in different ways. Mental health is very personal to people, isn't it? If we generalise about it too much, it doesn't work. I think the context of mental health is really important. Hello.
Thanks. I've got a question. I really love that you're talking about discrimination, inequalities and racism. I think that's a fantastic focus for this. But I reflect on the fact that most mental health research excludes those people. And when you try and answer questions about helping people from black and minority ethnic backgrounds who are being compulsorily detained, or helping people with bipolar disorder who are experiencing racism, there's nothing. So how do we bridge that gap?
Good one, Andre. How do we bridge that gap? What do we think?
Well, I suppose that this is a systemic problem when we're thinking about inequality. So I was having a conversation earlier that it starts with those who are funding the research in the first place, because they will define what is worth knowing. That then it comes down to the researcher who defines what within that sort of those boundaries, what we should know, choosing then what methodologies we should use. That in itself will then also shape how you're able to engage with participants, so who you're actually talking to in terms of understanding of the experience, or anything around like mental health. And again, depending on different methodologies, there'll be issues around representation in terms of the sample. So that as you kind of get deeper and deeper, you tend to find that actually the experiences of black people become less visible. So I would say it starts with those who are funding it. Fundamentally, if the issues of those who experience the worst outcomes is important to you, then researchers will research it. And then if we want to know what questions we should be asking, we really need to be asking communities, what's important to them.
Other thoughts? Yeah, please.
Just to follow up on that question, I was wondering, as a researcher, what we can do to make sure that when we do research, that we involve people in our research that are representative, that are not just expert patients, but that are actually representative of the population of people with mental health problems.
My answer to that would be to work out what it is you actually want to find out. Because sometimes what you don't want is someone who's statistically average and representative. What you want is someone who's really specific. Depends on what the topic is. Because, I can come, I can sit on this panel here and declare that I'm speaking for all people born in the West End of Newcastle in 1977. Definitely not. I can tell you that now. So in that case, I'm unrepresentative. Right? If I'm speaking as a person with lived experience of mental health difficulty, I'm unrepresentative because I'm here speaking to you. Because the majority of people are here speaking to you now. So it kind of, for me, it's about really focusing on what you want, because you won't actually solve the problem of not knowing the thing you're trying to answer by just getting some different groups of people to research. It's that actually, do you need those people to find out these things? Do you need to be guided by those people? Is this actually something that is relevant to them, or are they relevant to you? Because you can do a lot of stuff that's kind of tokenism in terms of diversity to kind of tick the box. And you go, well, we did diversity, and funnily enough, we found out exactly what we expected to find out, because we just found some people who were the right shape, the right background, the right condition. So I kind of feel like the answer to a lack of diversity is not tokenism. The answer to a lack of diversity is really examining what the questions are that you're asking. That's where it starts for me. Does that make sense to anyone else on the panel?
Yeah, and I think, especially when we think about involvement, it needs to come in very early in the process before outcomes are set. Because a problem with us researchers in prevention, and more broadly in public health, is that we set very simplistic outcomes. There's a lot of funding that aims to reduce suicide as a singular outcome. But suicidal ideation is quite a rubbish way to live. And so we should be thinking probably a lot about quality of life. We should be thinking about how people get through the day and what support they receive. So I think we tend to be very simplistic, and involving people with lived experience at every stage of the process, but from very early on, will definitely make us more sophisticated. And that, I think, brings me back to the point about resilience and strength that we made, because again, it's a very simplistic argument. Strength, resilience. Well-known TV personalities saying we should talk about mental strength instead of mental health. But the experience from family and friends and colleagues, for me, has shown that the strength that some people have to live through a day when through this whole day they're thinking life is not worth living. I cannot think of anything that takes more strength than that. So how can you claim that this person is weaker than everyone else? So for me, that really changes perspective.
So I'm going to bring it to the research side, which is often less engaging. So I genuinely believe that we need in research to be much more explicit about when our studies are not representative. And that when we write those strength and limitations sections, we say, actually, this probably doesn't apply to all these groups that we haven't got in our study. Because, when you write a systematic review, in which I do with Rachel, when you do your strength and limitations section, you always go, there is a risk of publication bias. But you don't in all these studies where, 99, there's like one person from a minority ethnic background, you never see explicitly written, this does not apply. And it's like, we recently did a systematic review looking at cyberbullying, and this wasn't about black minority ethnic populations, but most of the participants were female. This equally applies across sexes. So I think we have to be very conscious as researchers about how representative our studies are and who they apply to. I think we need to raise awareness and be more conscious of it.
And I think also that what we often don't do is also look at the politics of the researcher and the lens at which they are looking at a problem. And I think that's also a kind of fundamental flaw of a lot of research that we deem as evidence, and which we then decide to create our policies and our practices based on evidence that hasn't really maybe looked at the real complexity of the question that they're trying to answer. I think there's also something about researchers needing to change the way they work, and I think that goes across all sectors. There is that expectation that people will come to a meeting, and actually that might not necessarily be the format that somebody wants to engage with you, but it doesn't mean that people don't want to have an input. But we probably need to think a bit differently about how we engage with people, being really clear about the power imbalance. because we want to be all collaborative. But that actually means that you have to let go of the power. And, with my sort of short stint in academia, it's very hard for people not to be the expert. I want your views, I'm trying to canvass your views, but actually if it's something that doesn't resonate with me, then you'll find a way of not paying attention to it. So if we are really thinking about engaging communities, it means that you might actually have to look at something that doesn't seem to be of importance to you. And how do you build that? Because it's also about trust. Because if you're asking somebody's views, not taking them on board, why is somebody going to want to give you their time to engage in your research?
I think so. Inherently, a lot of researchers are curious about the world. So I think I'll talk about it. So I'm really open to conversations that make me look at different perspectives and different understandings. But I think where you can go wrong is understanding that there is a power imbalance. And I think it's having an understanding of those, where you hold those meetings, where you seem like the expert, where what people say triggers you, the beliefs that you've constructed. So it's recognising not so much how you might feel as a researcher, but how people might view you comes into the conversation.
Yeah, you were getting a lot of nods in the audience then, both of you, when you were talking. How can we be more creative about how we actually go about research? That power difference, that way of working, that not just come to a meeting at the Tower of Learning.
Hi, Neil Barmer from Mental Health Research Charity MQ. I'm actually going to ask Anne who MQ actually funds, so I should declare that now. And specifically, without wanting to go too granular into research, I'm interested to the extent to which data research can start to address, but also not address, some of the issues that Andre talked about marginalised groups and groups we might not get to. Because there's a sort of paradox with data research in that it's inherently faceless, yet it has the potential to do more than, it doesn't fall into the same traps as suppression. So I'd be interested in that.
So I think all research has its pluses and minuses, and one of the big strengths of like, in inverted commas, big data research is like, so we're increasingly doing research based in schools, about common mental disorders, so anxiety and depression. But anyone who's worked clinically will know that lots of kids with anxiety and depression and other emerging mental health issues, they're not in school. So we can talk about whole universal approaches, but they're not there. And the thing that mental health, that big data research does, it's a very messy voice, but it gives everyone a voice. It can link up anonymously, people in schools, people in general practices, people in populations, so you can at least get an idea of those sorts of groups that are really hard to involve in research. So for me, that with all its weaknesses, and it has a lot, that is one of the biggest strengths of big data research of mental health, is that often if you have mental health problems, the last thing you want to do is go and answer cohort study questions for 2.5 hours. Or whereas in big data, you have a voice.
Someone else wanted to come at back. Hello? So I saw a hand go up. Yeah. Hi.
Hi, my name is Thomas Kabir. I work for a research charity called the Pin Foundation.
Yeah.
Sometimes it gets slightly depressed that the division, particularly within the NHS, between mental health and physical health, and how the mental health problems of people with physical health problems tends to get ignored. And to some degree, I think it's replicated with research. Am I wrong? Is there anything that we can do to address this, to get good quality research into the mental health needs of people with physical health problems?
There's a lot of talk about integrated care. I've not seen much of it.
That's my point.
And I think you're absolutely right. There are some quite specific liaison services looking at mental health issues, and they tend to be contextual around accident and emergency, long-term physical conditions. But there's a lot more to be done. There's no doubt there's a big morbidity, isn't there? People who go off sick, perhaps with a physical health condition on their sick note, and then it turns into something quite different, say, towards the end of their sickness period. That's a huge issue.
Yeah, so if you're a 14-year-old child with a normal infection in a hospital,
Yeah.
you've got a serious cancer, just for the sake of argument.
Yeah.
What help would you get? What research is there to show what would help that person, for example?
Can you
I'm
help?
just trying to...
No, it's good.
You know,
Rachel and Josephine, can you help at all on that one?
Yeah. I mean, I think, well, from what I know from the research, there is a huge capital investment and not every is also not a lot of focus, as far as I know, on mental health conditions and people with long-term conditions. We've done a project in Scotland looking at that for young people, and basically it required a project to profile it and to focus on that. And I think what's also really important with that is like the ongoing focus, because with that it's a project, it's there, but then what happens afterwards, and how can we really make sure that that learning is being taken forward and updated. So yeah, I think that's something that we really need to focus on more. I'm not aware of like the exact like split of research papers on this and that, but just from what I've been reading and observing, I think that it's a lesson.
Yeah.
And I
Rachel?
think,
Yeah, sorry, just then I'll come back to you. Yeah.
I was only going to really echo what Josephine was saying, and you know, this is exactly the kind of question that we need to hear about, so that we can identify potential evidence gaps. If we look for that evidence from primary research and we don't find it, and we can't synthesise it, but it's an important question that's come from the people who, you know, really need it, the audiences we're trying to engage. That's something that's a research priority that we send back to our research partners who are very welcoming of that kind of information, because they find it as difficult as we do to acquire information about where they should be pursuing their research.
Is it on this point?
Yes.
Yeah, please.
So if I remember, it was something that came up in the CQC review of deaths within the NHS estate, and the two groups that were most likely to die within the NHS estate who were people with physical and mental health, with a physical health condition and a mental health condition, and people with a learning disability.
Yes.
It's definitely something that's kind of come up in our research as well.
Yeah. One of the things to look out for, perhaps at McPin and elsewhere, is there are the Mental Health Plus network bids. There are 8 of them. There's certainly one in York. There's one in Edinburgh, I think. There's quite a few UCL-based ones. There's 8 of those, and they're cross-sector bids, and they're looking. So the York one is looking at, it's called Closing the Gap, and it's looking at the mortality difference between people with severe mental illness who are dying from physical health issues. That, I think, is quite helpful, but it's very recent. It's literally the next 4 years.
But like, kind of addressing that question though, isn't that another example of kind of the diversity problem, in that we have data, we have experience, we have knowledge, we have research on this category, and we have knowledge and research on that category, and you know, there is an intersection between categories generally in lived experience where things kind of overlap, and it's really interesting that we have to talk about comorbidity to talk about effectively intersectionality, which kind of really confuses me. It's like we have to go, like, to get to the point of going that some people are different from other people. We have to talk about some people have medical conditions and some people have mental health conditions, and then maybe we can get into the idea that actually people are quite different from each other, even if they exist under the same umbrella.
So I think you're really right that lots of people with long-term conditions, lots of people with physical health conditions, or who have heart attacks or facial scarring, that there's lots of things that affect them both physically and mentally, and we have lived in a world that has separated those two things. All I can say is I think more and more we're demonstrating that it's a co-directional impact, and big data is actually big data surveys. They're really good at doing that. So it is about, and I think research councils, funders, researchers are increasingly interested in that. So you've got people with mental health problems. So it is people with severe mental illness, but also people with anxiety and depression have what we call premature mortality, die early. But then people with physical conditions have mental health conditions. And actually, it's people have all these things. And we have to try and understand their impacts and how we minimise the adversity of those things that they have.
But we have a duty also in this partnership to make that case, and I think that's really where we have a strength, because we have between us access to so many different audiences, and it's not just the research community or research funders, it's the care community, it's health and social care and the way services are organised, and indeed, as you rightly pointed out earlier, the way society functions. We haven't made enough of a case that there is no health care and mental health. We can use this partnership to try and really, influence that conversation.
Antonis.
I think part of the strength, to reiterate, that part of the strength of partnerships like this, and not to blow our own trumpet, but also, Network Plus, the new site, is that they are now embracing the complexity a lot more. Because I think part of the problem with that division between mental and physical health has been that for years the extreme outcome of mental illness was always suicide. But then, what about all these factors that lead to that premature mortality? So we haven't addressed it in research, I think, partly because it was too complex, and partly because the healthcare system was too divided. But now I think I see that. I'm encouraged because I see researchers and partnerships and networks embracing that complexity.
When you're worried about this, you don't necessarily worry about this, as my wife keeps telling me.
And then we know how closely the two things are associated.
Absolutely.
Bi-directionally, people who have physical health problems are much more likely to have mental health problems, and vice versa.
Yeah. Any thoughts back on it was a good challenge. Any reflections back?
I think it's about bringing the two worlds together.
Yeah.
And that could be as simple as having the same IT system, for example.
True.
If two different organisations have computers which don't talk to one another, that's going to make the world for everyone, including researchers, very, very difficult. I know the NHS and IT don't have a history of that, for example, and that's feeding into having good quality data. So we know what the scale of the problem is, and of course everyone, we're all people, we all have mental health and physical health, but we need to know what both sides of the equation are.
Any other thoughts, comments? New topic. Hi, hello.
Hi, I'm Creary from Mental Illness. So a slightly different question. So when we're thinking about research, we kind of have to question what is the entire purpose of having research in the first place. And we've thought a lot about research as a way of investigating different issues, but actually maybe it's time to kind of think about research as a way of bringing power to people who historically not had a voice. So I kind of have a question for the room more broadly. So when we're thinking about co-production and we're bringing people into research, are there really good examples of bringing people in at different stages? At what stage is it good to bring people with lived experience in? Is it from the research design? And what level of involvement people with lived experience got in that research project? Are they, they have as much of a stake in it as, the research themselves? So that's my question.
Great question. So where and how? Do you want to kick off that?
Got really excited. I kind of think the answer to that question is to really know what people are already doing. Like, one of the first things in that is what research are people already trying to do who experience mental health difficulties, and can you give them a hand, which kind of pulls you actually further into the kind of agenda of kind of social justice and reparative justice and kind of changing the world. So what is it that people who experience mental health difficulties are trying to change now? and what can you bring as additional resource to changing that? So research is a skill, data analysis is a skill, talking to people is a skill, getting up before 10 o'clock in the morning is a skill, so I hear. Answering the phone, all those things, they're all skills. So the question for me is actually what are communities currently already trying to change? And can you be involved in that? And also thinking about where there are points where actually the prevailing wisdom of people with lived experience is actually really rubbish. Because I think there really is a big challenge in that there's a lot of people don't believe that change is actually possible. They can't envisage, I suffer from this, lots of other people suffer from this, not being able to envisage a future that's any different from the future now. So what we kind of do is we kind of think all we need to do is perfect the present, which is kind of a challenge because we don't necessarily have the answers to how the world might be better in the present. So in some ways, you have a role in inspiring, you have a role in responding, and you have a role in just being helpful. I think that one of the things you can ask is, can you help us? But also ask, can we help you? And I don't actually see that happening very much in research. I don't see researchers embedding themselves in communities. I see communities trying to embed themselves in research, and that often doesn't work because there's not really a mutual agreement. Thoughts?
Yeah, for me, I think community should be involved in framing the research from the start. The level of involvement, I think, really is down to the people you're engaging with. So for some people, they want to be involved in all aspects, and for others, it might just be, reviewing the report at the end, or somebody wants to, others might want to be active in collecting data. So I think it's about having that flexibility, but also that, you might engage people at the start, but actually, again, having that flexibility that if other people you meet along the way want to be able to get on board, that there are opportunities for that to happen, rather than, I've engaged with my 15 people now, so we can't possibly take anyone else on board. So I think it's about working, I think, a bit more organically, I think is really important.
So I really agree with, we talked about it earlier, about the thing is the way people want to be involved in research is very dynamic, isn't it? And there's lots of different ways of doing it at all the different stages of research. I think that sometimes it's almost like we pitch each other as adversaries. And I think that concept of being helpful on both sides, in that, to remember that researchers are people living in communities and who have mental health problems, and having an awareness of how difficult it can be for other people to engage when they're in different roles and different environments. I have a PhD student who approached me to do a self-funded PhD who had lived experience of the thing that we're studying. And in our initial conversations, we worked together for 4 years now, so most things ironed out. But initially, some of my, I need to meet you a few times and talk this through, was understanding whether, because doing research, being actively involved, learning, that's hard work, it's challenging. And if you're doing it in a topic that you have experience on, that can be very difficult. And we got there, but for some people you might not get there. I think in research we have we're set up that, if someone starts a PhD with you and doesn't finish it, that's a really, really black mark against you. So sometimes I think it is about opening up the system to understand that actually we need to be more fluid and dynamic about things like that.
There's perhaps something about co-production as well. You can take two attitudes into co-production. You can want to relieve the situation because you've got all the expertise and answers, or you want to enable the situation. And I see the clashes when somebody's in relieving mode saying, well, I've got the answers, you just need to follow them. And that person wants to be enabled. Actually, give me the evidence, I'll think about the choice I'm going to make. So enabling and relieving are the attitudes you can take into a situation. And I think in the NHS, which I know a bit about, we've trained a lot of professionals to be in relieving mode with the expertise to support patients. And in research, it's a pathway. There are various points along the pathway where there's obvious synergy to really encourage involvement. And I think we should point them out and be clear about them and encourage the different types of contributions that you're going to get and be more flexible about it. Does that make sense to you? Yeah. Keep going at Rethink. Great. Rethink mental illness. Fantastic. Great.
I think one of the biggest things is we've really focused on definition and diagnosis, both in research and sometimes actually in services as well. And I think we need to think about much more about context. You know, so the experience and meaning and what happens to you if you've got certain mental illnesses will be very different depending on the context of your life. And also about function's a horrible word, but how you can get on in the world. So I do think there has to be, as well as prevention, a bit of a shift to that sort of research.
Just a quick parenthesis on this topic, and I'm glad the conversation went there because, by the way, I'm having a very inspiring day, largely because of the conversation, but partly because this morning I took a little bit of break from the classic day-to-day and I did an exercise into identifying some of the highlights in the Mental Health Foundation's history. And I think one of the reasons why we're very, me, but also I think colleagues, very proud to work at the foundation is pioneering some of this involvement work back in the 1980s, actually. So I think I was looking again at the history of the foundation and I was getting inspired sitting at home working by how the foundation started doing some of these meetings and events and conferences and surveys. And I have a colleague in my team who actually has a letter of an invitation of 1989. He was invited to one of those. So I'm glad the conversation went there because I think it also reflects some of our past, which was mentioned, and also some of the important future.
I hope you noticed that for Antonis' appraisal. Very good, really good point. We should be proud of the history where it's worked, and we should amplify it and celebrate it. I'm just sensing there's 2 or 3 more minutes left. If there's a final question you'd like to really interrogate the panel on, please do. There may be something from outside.
There is a question from Twitter from Ian Hamilton, who's a mental health nurse at York University.
Yeah.
He said, what about drugs? What about addiction? Does that have an impact on mental health and mental health research?
Okay. Quick. Let's have a quick answer. Public health perspective.
Yes.
Thank you, I'll take that back to him.
Bi-directional. And I think one of the things when you're thinking about prevention and public health and mental illness and substance misuse is about those universal interventions, minimum unit pricing. The evidence is there for lots of things. Yeah. We just don't implement it. So I think the phrase is like 17 years to get research into policy and practice. Average. Which means sometimes it happens quickly, usually because someone will save a lot of money, and sometimes it takes 34 years. There's loads of evidence out there about substance misuse.
Yeah. Other thoughts on that?
Come to say drugs and alcohol, especially for this country. But I think again there is that complexity that we have been avoiding on this topic. So. I see more research on that, which is encouraging. And you had some points around also how to ignore it.
Yeah, so I was just sort of recalling a conversation that I had with a researcher. So at Black Thrive, we see the importance of aligning with researchers. So we are sort of now exploring opportunities to sort of work in partnership to help inform the work that we do. we were approached by a researcher who was interested in looking at certain risk factors for being sectioned, and she was interested in alcohol and cannabis, and I was just struck that opiates weren't also considered. So again, depending on your lens, that can impact on, again, the questions that you ask, the factors that you're looking for. So it's really important that you are actually having conversations with people who are either have lived experience and working in that space to help inform your research.
Thank you. Good stuff. Final comments? Yes, hello.
Hi, Richard Woolley. I work for Cochrane. I'm a consumer engagement officer. I'm conscious that we're having this meeting in the UK, and I don't know how much of an international audience there is here, but should we? How could we think about how we address some of these issues from an international perspective?
Absolutely. Yeah. It was a real dimension to that first question, wasn't it? We were talking about why are so many different backgrounds excluded from research. Well, if you go global, that's much less likely, although the context changes. And context is really important in mental health and wellness and well-being and all that. What's your thought on that as a Cochrane sort of host?
I'm mindful that Cochrane is an international organisation.
Plenty of satellites, as per the slide.
But I know that I'm also guilty of thinking of things from a UK perspective.
Yeah.
And historically, Cochrane, started in the UK.
Absolutely.
And we're trying to extend the global reach with new partnerships and so on. But it's a challenge in terms of consumer involvement in Cochrane, patient involvement. Half of the people are based in the UK, so it's something we need to address.
One of my brief experience was in China. It was highly respected. Certainly 5 years ago when it was launched there, it was a highly respected name, and whether it is now, I don't know, but it was something that had resonance in quite a closed society at times.
I think just on that point in terms of global mental health, I think it's usually really worth looking at the UK from the perspective of other countries rather than looking at what the UK's perspective can give to other countries, because we might be a little bit surprised at how we look from outside. Because to be honest, it's kind of quite surprising how we look from inside, depending on where you're standing.
Italy and New Zealand would have...
I was going to say something actually very similar, that I think, thinking about global mental health, one of the things that we're actually learning from our global mental health colleagues in the satellite that have very much a lower middle income country focus is that actually probably the sorts of things that we're interested in doing, sort of environmental interventions, engaging people, things that actually aren't health service driven but are further upstream, preventative, we can learn an awful lot from them, because they haven't had the magnificent resources that we've had that have somehow equipped us with this marvellous health service that separates mental and physical health and actually doesn't apparently deal with the needs of patients, and alongside it a research agenda that probably doesn't match the needs of patients. So it feels to me, for example, some of the things that are going on in that sort of space are reviews around non-specialists in involvement in helping people, peer-to-peer type support and so on, because they've had to think about things in that way. So I think it even goes beyond what you're saying, Mark, that we should be looking at them actually for inspiration, because we've run out of ideas here. We've clearly not got this right. We need to have a complete rethink about how we approach this. And one of the reasons that we've tried to situate some of our satellites in other countries and with a specific focus is because of that need to get away from the kind of UK perspective and think about what we can all learn from one another.
Thank you, Rachel. Let's finish that point international. That was a really good point on how do we reach outside in the very, very strongest possible way. I'm just going to say thank you to the panel. I know there's some wrap-up conversations, a little bit of feedback, I think, from Mark and others. But can we thank Anne and Natalie and Antonis and Mark for their really interesting contributions and for coming to the British Library and bringing it alive for you. Thank you very much.